Thank you, Kevin. Dana, thank you for the invitation to present. I enjoyed putting together this presentation on managing bile reflux after bariatric surgery. I have no relevant financial disclosures. So first, just to start with the presentation and symptoms, main symptom is going to be epigastric pain, probably from bile gastritis. There may or may not also be nausea and reflux. Obviously, bilious vomiting proves the diagnosis of bile reflux, but may not always be a symptom. I think it's appropriate also to start with treating and managing standard acid reflux therapy. So as far as making the diagnosis specifically for bile reflux, not just reflux in general, bile can be visualized endoscopically as seen here in the proximal roux limb or of course, in the stomach or gastric pouch. There's also the option, as was mentioned earlier, for a 24-hour bile monitoring, which is shown here, the catheter along with a pH catheter. This actually works by spectrophotometry, looking for the color of bilirubin, and you can see you can get a tracing here of pH and bile reflux. You can also do cholecystography, otherwise known as HIDA scanning, to diagnose bile reflux. And then multi-channel intraluminal impedance monitoring will show non-acid and bile reflux as well. On endoscopy, if you're able to reach the jejunojejunostomy, you may diagnose a short alimentary limb. And again, there may or may not be bile gastritis in the pouch. So a bit about medical therapy. So there's some information on baclofen in terms of reducing esophageal reflux. So again, in the context of bile, this will help with the esophagus or esophagitis, but not with the gastric or pouch gastritis. And the way that works is as a GABA agonist, it will diminish the transient LES relaxation time. It's given before meals and slowly titrated up every 3 days or so as needed. The main thing that will limit titration and effectiveness of this are the side effects as shown there. There was also an interesting study looking at citalopram, basically by just reducing the perception of esophageal reflux, and again will only help with reflux making its way to the esophagus. Helpful for those folks with the so-called hypersensitive esophagus. Standard dosing 20 milligrams a day, and there was an interesting placebo randomized control trial showing a 62% resolution of reflux symptoms versus 33% with placebo. And of note, this was in combination with standard acid reflux therapy such as PPI. So as far as surgical options, treatment options, it's interesting and helpful to review a little bit of our surgical history. In fact, actually, the original gastric bypass described in 1967 by Mason and Ito involved a loop gastrojejunostomy, which was abandoned partially because of bile esophagitis, bile reflux, as well as marginal ulcers and leaks. Thankfully, however, quite a few years earlier, Cesar Roux had proposed another operation. He was a Swiss surgeon, as you may know. He described the ANSA-NY, or Handle-NY operation in 1893, which was for gastric outlet obstruction and bringing up a gastrojejunostomy as opposed to a loop gastrojejunostomy solely for the purpose of minimizing bile reflux. Interestingly, his alimentary limb was only 10 to 20 centimeters at the time, and was actually abandoned due to marginal ulcers. But again, keep in mind this was a situation of a large portion of the stomach anastomosed to jejunum. I also found in reading about Cesar Roux this sign from his hometown of Lausanne, and if I'm not mistaken, that would make that street named after him, the Rue Cesar Roux. So then based on Dr. Roux's anatomy and idea, Griffin popularized what has now become the standard form of a gastric bypass. So looking at options for bile reflux after gastric bypass, thankfully Dr. Felix and his group published something, otherwise I'd have very little literature to show you here. So they talked about their experience of treating bile reflux after gastric bypass. A series of 16 patients over 4 years, all with bile reflux, most of which had been done at their center, but there were a few patients that came to them from elsewhere. All of these patients had epigastric abdominal pain. Most had regurgitation and vomiting, and a little less than half also had dysphagia. Interestingly, there was quite a bit of a delay of onset of symptoms after about 58 months on average after their original gastric bypass. So in their study, the diagnosis of bile reflux was based on the finding of bile as seen here in the gastric pouch. About half the patients there had gastritis, and about a third had marginal ulcers as well. When the JJ could be found, they found the average length was about 40 centimeters. They also ruled out other sources of abdominal pain. Interestingly, most of these patients had previously undergone treatment for some complication, such as internal hernia, and then a couple of things that may have been due all along to the bile reflux. Their revision operation was a lengthening of the alimentary limb. When they took these patients to the operating room, they found that the alimentary limb lengths ranged from 20 to 62 centimeters. And the op notes available in most of those patients actually documented an alimentary limb or roux limb length of at least 75 centimeters. So the question was it mismeasured, or did it get shorter over those months? No one knows. And their revision operation was to divide the biliopancreatic limb at the JJ and then move it distally to 100 centimeters from the gastrojejunostomy. All of these operations were done laparoscopically, and then at a median follow-up of over a year, all patients had complete or near complete resolution of symptoms. About half the patients had reason for repeat endoscopy, all of which showed no signs of gastritis or bile. Now, there's some controversy, as was mentioned already this afternoon, about whether the mini gastric bypass causes bile reflux. The most recent study is this series of 1,000 patients in Lebanon, and they found that in patients with a primary mini gastric bypass, there was no bile reflux. However, in their series of patients who had a revision mini gastric bypass, the percentage of bile reflux rose to 5%, perhaps because with the revision, the stomach pouch was made shorter. And their treatment was to staple the afferent limb proximal to the GJ and then do a brawn enterostomy at 70 centimeters. And they found that revision was entirely effective at resolving the bile reflux. There is another study out of the United States that does not comment specifically about the incidence of bile reflux after mini gastric bypass, but this multi-institutional study from the southeastern United States reported their experience of treating outside mini gastric bypass patients presenting with complication, and found that the most common presenting complication was bile reflux in 20 of those 32 patients. The diagnosis was made by bilious vomiting or abdominal pain, and then bile gastritis on an upper endoscopy. And the revision in most of these patients was conversion to gastric bypass. 2 got a brawn enterostomy, and at the time of the publication, 4 patients were planning to have gastric bypass, and they reported that those revision operations were completely effective at treating the bile reflux. I did not find any literature specifically referencing bile reflux after sleeve gastrectomy, but obviously there's a possibility of such a thing, and I think conversion to gastric bypass would be the sensible solution. Thanks.